Welcome to the smartest doctor in the room. I'm your host, Dr. Dean Mitchell. Where can you get the best medical advice anywhere, anytime? I hope on this podcast. Today's topic is back pain. Ugh. Just saying those two words make me cringe at times. I can cite statistics like 1 in every 4 adults has experienced back pain, but truth be told, when you're the person that has that awful back pain, it's you. You don't care about any statistics. I had my own personal battle with back pain. I was a healthy high school and college tennis player, never had any aches or pains, could play for hours tennis. And then I got to medical school, was where I experienced my first episodes of back pains. And I attributed it to sitting for hours in a classroom. I would be in the classroom from like 8 in the morning till 5 at night. And then more hours sitting on my butt studying, to learn anatomy, physiology, all that fun stuff. But the episodes were short-lived, and I usually got better within a couple of days with just some rest and ice and movement. Then a few years later in medical residency, I was up all night caring for patients and bending over a lot, doing IVs and procedures like lumbar punctures. And again, my back pain came back, and this time with a vengeance. It would last for weeks at a time, and I would use all sorts of treatment, ice. I went to physical therapy, and I was constantly walking around with my lumbar cushion whenever I was sitting in a car or I went to a restaurant. So I can say one thing, though, looking back, that my back pain was actually a blessing in disguise. And you may ask why. Well, it actually was one of the things that pushed me in the direction of holistic medicine. I initially saw an orthopedist for my back pain who put me in a brace, and I quickly knew that wasn't an answer. I ended up seeking help from physical therapists who were excellent, and actually eventually met an osteopath who definitely changed my life with the way he manipulated my back, and he taught me various kinds of exercises that seemed to help me a lot. A lot of times too, unfortunately, I was always my worst enemy. I would, do certain exercises or see it in a magazine, and before I knew it, the next few days I could barely move. My guest today, Dr. Stuart McGill, is an internationally recognized lower back specialist. He's a professor emeritus of spine mechanics at the University of Waterloo in Canada. He has researched his entire career the causes of back pain, and he has worked and treated thousands of patients in his clinic using his exercises. He is the author of several terrific books, which I have and I've read reread many times. The Back Mechanic, which is one I actually recently read and enjoyed. I really liked a lot also his book, Lower Back Disorders. And I like for athletes his Ultimate Back Fitness and Performance. These are all terrific books that show you, hopefully under the proper guidance, how to carefully strengthen your back. And, although he's not a medical doctor, I think that's why so many of his grateful patients are glad that they avoided having to have surgery. He also is now the chief scientific officer at BackFitPro, a company that makes, I believe, educational and practical products for back pain sufferers. So it's my pleasure to welcome Dr. Stuart McGill to the podcast.
Well, good afternoon, Dean. Thanks for having me.
My pleasure. Okay, we're going to get right into it. And probably one of the first most important questions that any person with back pain has is, who do I go to for my back pain? In the United States, we have lots of healthcare providers that are treating back pain with varying success. We have orthopedists, we have physiatrists who are in rehab medicine. Of course, we have chiropractors who are doing adjustments, physical therapists, there are osteopaths, and acupuncturists. So, Dr. McGill, I'd like to ask you, if a friend of yours was across the border in Michigan and called you up and said, Dr. McGill, I've been having back pain for a few months now, who would you recommend I go see first to get an evaluation?
Well, I will create just a little bit of a background before I give you the specific answer.
Sure.
And that is, Dean, as you know, there's no such thing as non-specific back pain. It's like if you asked me that question, oh, I've got head pain, who would you suggest? Well, we would need a very thorough assessment to understand the mechanism of why you have head pain. we would subcategorize your head pain and then find you the most appropriate expertise. So I'm going to answer back pain in exactly the same way. But here is the issue. No single profession that I'm aware of, and I've worked with them all, is trained to do a thorough assessment of back pain.
Great.
You have to subcategorize that person down. Now, to perform a thorough assessment requires a very thorough understanding of biomechanics, anatomy, neurology, movement, psychology. You have to really know how to probe that pain. And then the first order of business is to stop the cause. So if you go to your family doc and you get a pain med, you never saw a back pain expert who measured the cause and then intervened at that level. If you go to a surgeon, you are speaking to someone who uses a knife that will hopefully cut out the source of the pain. And I can go through the full litany that way. So unfortunately, we've had to train our own clinicians. We call them master clinicians in the McGill method, who take several years actually to go through the various schooling and different.
What is their background? Are they of different backgrounds? I mean,
yes. Yeah, yes. To me, it matters.
It doesn't matter what their degree is, which I think for most patients, and I found in my own career, it doesn't matter what, I mean, it matters, but it doesn't always matter, you know, what the initials are behind their name. So,
well, that's correct. We have MDs, chiropractors, physical therapists. We even have a strength and conditioning coach who has met the level of master clinician. He can read an MRI, and I'm sorry to say this, but more effectively than most radiologists, because all of us see the patient first. We know and we've measured their symptoms. So then when we look at the MR, we're calibrated, because the picture, the MRI, shows the full history of that person's life. All of the old scars plus the new fresh wounds that are causing pain. And you cannot interpret an MRI until you have the perspective of knowing what that person's mechanism is. So do you see?
No, yeah, this is a great point. You know, what I loved about what you write about in your books, the back mechanic especially too, is that, which unfortunately doesn't happen a lot in the United States, because they have so many assistants, you know, taking history and doing this till the doctor, you know, strides in. Like you said, you watch how the patient enters the room. You watch the patient, how they get up and out of, you know, a chair. You know, this, you know, again, in the United States, doctors don't get reimbursed for watching you get up and out of a chair. But like you mentioned in your books, you learned so much along with a good history of where the problem is emanating possibly from. Is that correct? Am I saying that correctly?
Yeah, I think so, but there's a genesis to that.
Okay.
When I started the back pain clinic at the university, I had free reign to start from ground zero. Mm-hmm. And I thought, how am I going to set up an assessment that is all based on outcome? We are going to be measured on our outcome, not on how many dollars we generate or on how much time we spend or how many patients we see a day. We will be measured solely on outcome, which is really what the outcome, I mean, nothing else really matters.
Well, it's not the patient, it doesn't.
That's right. Yeah. So I started out setting aside 2 hours to see a back pain patient.
Oh,
and my medical colleagues said, "Are you nuts? No one spends 2 hours." And I said, "How can you not spend 2 hours? Because it takes me 2 hours to perform a thorough assessment."
Right.
It starts out listening to the story of the person. What are all the impediments that has stopped them from getting addressed and cured by the dozen other clinicians that they've seen?
Right.
And then we perform provocative testing. We create the pain, knowing the specific activities, motions, postures, and loads that create the pain. Then the next order of business is a little bit of a coaching session, which is a little bit of an experiment in progress. Mm-hmm. If you slouch in a chair and that causes your back pain, but you look up and that causes your right toe to go on fire, that's a very primary indicator of a neural underhook on the nerve root serving that
Right.
toe. If it's the big toe, it's L5. So we're getting very precise now.
Yeah, but it's
Now,
important.
can we give that person a movement strategy or a hack on how they can now avoid that? So instead of bending over and tying your shoe, replicating that pain trigger, unbeknownst to the patient for the first time, we can give them a movement hack where they stand up, put the foot on a chair, and then move the hips to the target, which is the key. And then they tie their shoe, completely avoiding the mechanism. Then we get into the psychology and neurology of winding pain down. If you stubbed your toe today, it would be sore. And if you stubbed it again tomorrow, it will become even more sensitive. If you stub it on day 3 or even lightly touch it, you will scream. This is what happens to people with back pain. They keep stubbing it or picking the
That's
scab.
a great point, right? You keep on you don't realize, like all of us, you end up doing the same motions, whether you realize it unconsciously or consciously, and breaking bad habits is difficult.
Right. So anyway, to get down to really answer your question, there isn't a profession that knows how to thoroughly assess a back.
So you're basically
all the way through.
So people have to get in a car and drive to Waterloo, Canada.
Nor are they coached.
Yes.
So now you need coaching skills. And it's interesting when patients come, they'll say, you know, you're the first guy who hasn't treated us like a 5-year-old, giving us a little silly explanation. You know, here's a person, they run a country. They are a president of a country, or, you know, they run a large organization. They're not fools.
Yeah.
But they appreciate being treated like a savvy, intelligent adult, showing them the real deal of what is causing their pain, and here's what you need to do to wind it down. And then the next conversation is, what are your goals? Most people, well, the athletes who come, the amateur athletes, they'll say, oh, well, I want a personal best. I want to be able to deadlift 200 kilos or something.
Right.
And I said, really? You do? I said, your history, you've got 3 grown children now. You're going to be a grandfather soon. Is your goal really to be the best rocking grandfather when you're 65? Because if that's your goal, going for the next personal best has just decreased your ability of being that rocking grandfather.
Yeah.
So let's be clear now on what your goals are. So we have a very precise target, and then we are going to choose precise tools matched to your very precise mechanisms to build the foundation and then progress it to get you there. So do you see this assessment?
I see what you're saying. Let me ask you one thing too.
One thing that will blow the minds of many of your colleagues. I then had to shift my 2-hour assessment to a 3-hour assessment.
Whoa.
Now, some physicians and hospitals will say, well, we can't afford to practice like you. And my answer to that is, you cannot not afford to practice because you bill for your time.
Right.
When people fly in from around the world here to get 3 hours, and for the first time, they leave with a very solid direction on what to do.
Well,
15 minutes doesn't do it.
Yeah. You know, it's interesting because I'm not sure how it really works in Canada, but it would make so much sense for insurance companies, which control obviously a lot of the access to healthcare in the United States, that somebody with back pain seeing you versus going for the MRI, all these other testing, seeing 3 different specialists, financially, it would be better for the insurance company and obviously for the patient to go to somebody like yourself who's doing that very extensive evaluation and setting up a program. So, you know, again, the whole issue about it's not cost effective. I agree with you. I think it's cost ineffective, you know, to be having people shifting around. I mean, you should see so many patients here when they start having back pain or are involved with pain management, which I really don't like. They're just getting shot up with, you know, injections and things like that. But I want to get back to one thing though. And again, I know this might be a little hard to pin you down, but if a patient goes to see a provider, can you remember, they're going to choose somebody, whether it's a chiropractor, osteopath, somebody who they associate with treating back pain. Do you feel that there's a few things that really should not be overlooked in the physical diagnosis? Like, you're seeing the patient bend forward, checking their spinal curvature, having them do, I mean, again, I remember my orthopedic, my brief orthopedic training in medical school, like, the crossing the legs over, checking for herniation. Is there anything that you would say to a patient, again, just in some, simple advice that, because again, if somebody just walks in, oh, here's your back pain, and they just look at it and they press a couple of discs, and that's the full extent of the value of the physical exam. Obviously that doesn't sound too adequate.
Well, realizing this, that's why I never thought I would write a book for the lay public. I only had written textbooks for clinicians. But interesting, some very savvy lay people read those books and said, could you write a book for us? And it was the most difficult thing I ever did, but I wrote a book to guide the lay public. So you have it in Back Mechanic. That was
the Back Mechanics, right?
And in chapter 6 are 9 tests that a person can coach themselves through. And then based on the results of those 9 tests, they will know what to do and what not to do for the first time to wind down their pain. So that was why that book was written, because they will not get the most simple of what I would consider an assessment to show them what to do and not to do. So, you go and see a surgeon and they say, go do yoga, right, or swim or something generic like this. Right. And there's the yoga may help them. There might be 2 or 3 yoga exercises that may help them, and there will be 3 that will hurt them. Right. So, it's too generic. It doesn't make sense.
Yeah. No, I think the book is great. It's interesting you say it was difficult to write, and it's funny in some sense. I would say it's been easy to write only because you were essentially doing this with your patients. Because you were, it's like myself when I sometimes, I'm used to speaking to doctors or giving lectures, but I found it over the years when I've written a book and written articles, that geared to the lay people, I just picture myself that they're in my exam room and I'm talking to them as if they were just there one-on-one. And that to me helps me write. But anyway, it's so funny out of your
what
book.
Made it so difficult, Dean, was this. There has to be truth and veracity in everything that we do. Sure. So the book difficulty was seeking the balance between being thorough enough and truthful enough and still making it consumable. And that was the dance. So I couldn't overwhelm them with detail.
No, it's true.
But I had to figure out what was the essential.
Yeah, no, it was really, I thought, very coherent, and well put together. All right, let's move on to something else I want to get to, because again, I also want to hopefully give listeners some specifics that will be helpful to them. So, ergonomics. Today, so much of our day is sitting in front of a computer, especially on Zoom meetings. I'm doing that now with patients. My patients are doing it for their work, or people who like to surf the internet for hours. I want to ask you how we can best protect our backs. And I know you make some points in the book about this. So let's start with sitting in a chair. Are there certain chairs that really are better than others? I know for myself, there's certain ones that, especially when I was having back pain, there were ones that were much more comfortable than others. I like the point I'll just bring out, what you make, is that it's not always so much the position you're sitting with, it's moving around, because you could be sitting in the best posture, but if you're sitting that way for hours, you're going to develop problems. So I was wondering if you could, give us some pointers on, again, people who are really desk bound, more than before, what they should be looking for, or who they should work with to make sure that, again, what they're doing by sitting, not exacerbating or creating back pain.
Well, there are several things to unpack here to get to an answer that will help people. And the first, as I've already mentioned, there's no such thing as non-specific back pain. We need to do the assessment so we know if sitting and what type of sitting is causing their problems. The second foundational principle is biology does not give you free lunch. It does not give you infinite capacity to load. Load is magnitude. Load is frequency of application. Load is duration, which is sitting.
Right.
A generic answer to that one is you cannot sit all day and expect to have a healthy back.
Right.
But there's nuances to this.
Right.
There are some people that's so unfair. They're just out of shape or condition, couch potatoes, and sitting doesn't bother them.
Those lucky people.
Well, hold on now. And
I'm joking.
Then there's the poor fella who's conscious of their health. They're desk bound for 10 hours a day, and then they go and train hard in the gym.
No, right. That's right. I mean, well,
they
just,
have more sitting.
Do you know, I had to say, my opening, I think what happened with me, when I was in medical school and I was in a warm climate, I would sit for hours studying during the day. And then of course, later on hours, but in between I would go play tennis. And again, even in medical school, I pictured I was still, a mini tennis pro, and I'd be playing like crazy. And then I felt like I tightened up or something, or, maybe I wasn't loose enough when I started playing. So yeah, the weekend warriors seem to be at the most risk, and they're the ones who are most frustrated because they want to go out there and exercise. They want to enjoy themselves.
You're right.
So what do you, what's your recipe? What's your prescription for their,
it's not that easy. It's 17 chapters in the book.
There's a reason we have this podcast. If it was easy, they wouldn't be listening to us.
Well, that's it. Let me give you some examples because you asked about here. So let me dispel some myths.
Okay.
It's interesting how many people come here and I'll listen to their story and I'm doing pattern recognition. And they'll say, oh, I have tight hamstrings with my back pain and I keep stretching my hamstrings. And I sleep in a recliner chair. I watch the TV in this beautiful, comfortable recliner chair. And I say, and that's why your sciatic nerve is so sensitized.
Right.
Get off the recliner. The recliner flexes the hips and extends the knee. You just put a stretch tension on a sciatic nerve. Right. Get rid of the recliner.
Okay.
Sit more upright with a lumbar support, because usually the upstream source of the sciatic tension will be discogenic. It's usually a disc bulge or something pathologic with the disc. So there's one start. Stay off the floppy couches. They might be comfortable to you, but they are not de-stressing the spine to allow it to become pain-free.
Can we go back to the chair though? I mean, because again, we're sitting a lot. Like even myself too. Sometimes I'm crossing my legs, or I'm
hold on now. Crossing your legs is almost. If I see a woman coming in and she's had 3 kids and she keeps crossing her legs, and then I say, "Can you sit with your knees apart?" And then in 20 seconds she's back crossing her legs. Check for pelvic ring integrity. You will find crossing the legs tightens up the pelvic ring, and they've found.
Well, why do we do that? Why do I do? I do that sometimes too. Is it just to change motion? Is it?
No, you test it, Dean. Test it. And
yeah, I do. I like doing it. But I think I read somewhere. I thought it was it puts extra pressure on the spine. No.
Well, it may be helpful or it may be hurtful. I don't know. But if we squeeze the pelvic ring around the iliac crests,
right?
And if the patient says, "Oh, that feels so much better," good. Let's walk. Oh, you've taken the discomfort away. Then when I walk. Okay, now slide the hands down to the greater trochanters.
Okay.
And squeeze again. I'm just going to get a model to show this.
Yeah, great.
And when you squeeze around the iliac crest, notice I'm binding the upper SI joints together and I'm cracking open the bottom ones. And then when I squeeze around the trochanters, I crack open the top and I squeeze the bottom. If one causes pain and the other takes the pain away, you've just identified a loose, pain-generating pelvic ring. Cross the legs, and you just tightened up the pelvic ring and made it more comfortable.
Okay.
But
no, those are good points.
Yeah, there's nuances.
I like that.
A thorough assessment will take you precisely to the target of whether crossing the legs is a good thing or a bad thing.
Let me ask you too, because also what's happened now, again, with ergonomics, I'm sure you've heard with, or seen, people now more too, they think they lose weight, whatever, to them now, they have the standing desks. I mean, some people, I don't know how they do it. They do it on a treadmill. They're doing their work or whatever, typing away at a computer, walking on crazy stuff. That to me doesn't seem to be very sensible. Like, I think people are going to get injured. But what do you think about people who like I think what's called Veridesk here in the United States. They have a desk like where, let's say if you've been sitting for a while, it has like a spring and it elevates so you can actually stand while you're doing stuff. What's your thoughts about that? Any?
It may be fabulous for a
Yeah.
certain type of person. So once again, if we take the
Mm-hmm.
typical disc bulge with an open fissure, that is one where the disc bulge shrinks and grows based on posture, another model.
Okay. Well, my listeners, when they get to watch the video on
So
YouTube, will get a
here
big
I'm going
benefit.
to show you if you sit for a long period of time with an open fissure. So you see the nice juicy.
Yeah, the pulp.
And now I'm going to squeeze the spine and bend forward, mimicking sitting. Do you see the little red delamination in the collagen at the end of my finger? Observe.
Yes.
Squeeze and flex forward. Did you see it open up? And the bulge coming out,
Yeah.
trapping the nerve root. Now,
Not good.
you stand up in the variable height desk, and now when I squeeze the spine, because the spine is not flexed, when you were flexed, the hydraulic effort was posterior on the juicy nucleus. Now the whole disc flattens, but notice nothing comes out standing. So if they have a posterior delamination, which most radiologists just call it a disc tear, which is just totally inadequate for the detail required that will help the patient, then standing up, or better yet, laying on the tummy, will vacuum in that disc bulge if it's a very specific type of open fissure. The bigger, the rounder the spine, the diameter, the faster it will resorb in. The smaller, slender spine, it takes more time.
That's a good point. Yeah. I like to, when I'm sitting, seeing patients in the office, in between patients, let's say it's 20 minutes or whatever, however long it is, I like to stand up, I like to move around a little bit. And then I'll typically also just sort of like reach to the ceiling. Was that like also sort of a good generic kind of,
Well, there's nothing generic. You will fail. Generic.
Okay.
Generic exercise.
There's no downside to anybody to do. I mean, could anybody get worse doing that? I mean,
of course there is. Pick a patient with stenosis, central canal stenosis. You just triggered their back pain.
By reaching up.
Of course, they get triggered by getting upright and walking tall. They are relieved by sitting slouched in a chair. So it depends on the category of pain.
What about the car? I want to get to that. I really want to get some specific things. People, I'm sure in Canada, but here in the United States, actually a little bit before COVID, I mean, people have to commute a lot. I mean, I drive from where I live on Long Island to New York City. It's an hour. I know I can't wait. I mean, for me, an hour is enough in a car. I mean, I'm ready. Even if I go on a long trip for a few hours, I take breaks every hour. You just feel like you're stiffening up. Is it important? Again, I know it depends on the assessment, but the placement of your legs, like how much an angle the knee should be, and I don't know. I mean, just again, if you had a guy who was a truck driver in Canada and he says, Dr. McGill, I got to drive 3 hours one way here and 3 hours back, and my back's been acting up. Well, again, after your assessment, what would be some general advice you would?
Dean, you changed the question twice. First, we started talking about you, and then
you're a real professor.
And then you went to, but no, I'm
joking.
I have to cure back pain because I'm measured purely on outcome.
Okay.
So come on now.
Okay.
We started talking about you, who's a doc who commutes to work, and then you shifted it to an occupational athlete who has to do it for a living.
Right.
Two totally different.
You're right. Okay.
Sets of. So in your particular case, chances are I would start by doing a hip assessment. So some hip sockets are very deep. Yeah. And if you sit upright in your car chair, it forces your spine to flex, stressing the posterior annulus.
Okay.
So what I would do there is raise the seat of your car and lean back the
seat,
the backrest of the seat. And then generically, we would try a lumbar support and see if that de-stresses.
Why? I'm sorry, again, why would you lean back the seat versus just being a little bit more upright?
Because if you're impinging the hips. If someone says, well, when I sit in the car, sit upright, I get inguinal crease.
That's a really good point. I know, right? A lot of people, and I know myself, right? Like sometimes your hips start to tighten up. When I've gone to people who've evaluated me or stretched me, they'll say, some hip tightness they'll pick
Right.
up.
I
So
mean, just
interesting.
watch me get out of a seat here. So
Yeah.
now I've got my knees together. If I
Yeah.
get out of the seat, I've got no chance to use proper mechanics.
Yeah.
And it might be when I do a hip scour exam, I've got lots of room when my knees are spread apart or
Interesting.
abducted.
Yeah.
But when my
Interesting.
knees are together, I get an impingement.
Uh,
So if I sit with my knees apart and get my feet underneath me, my hips can now move. I can de-stress my spine and stand up with zero pain.
I was just looking at your chair. It's interesting because obviously you sit there to examine people, I guess, or do stuff, but it has
Right.
no real back support. Is this just out of a convenience, or is it it's a
No,
special
there's a
kind of chair?
roll. We call it the Harley Davidson. So there is a roll
Ah, yeah, it
around.
looks very cushiony there. It looks very nice.
Well, there's stories on this. I had
Is that from BackPro Fitness? Is that one of their products?
no, it's from Princess Auto, which is equivalent to Harbor Freight in the U.S.
Okay.
So it's a fancy mechanics chair. But I had a drummer from a rock band who, if you're listening to the radio, you will know who I'm talking about. Debilitated with back pain to the point where he couldn't perform anymore.
Wow.
He sat on this stool as I was just doing the assessment. And he says, "This is fabulous," because the roll acted to tilt his pelvis forward. And that
Mm,
now allowed him to generate power in his legs so he could use the
mm.
hi-hat and the bass drum and all these kinds of things. So it
Interesting.
was a matter
Interesting.
of adjusting
Yeah.
posture change migrates stress from one anatomical area of the body to another. We
Right.
were migrating load off the posterior annulus and moving it onto other parts of his spine that were very resilient. So anyway, you're asking me how should I drive? I don't know, but if I could do an assessment or
Well,
one,
I'm coming to Waterloo.
I
After
don't.
this podcast, once the COVID restrictions are gone, I'm coming up to Waterloo to.
Well, good. I'm not there.
You're not there. Where are you? Where are you these days? Oh, you're Alberta. Where are you?
I retired from the university 4 years
Oh,
ago.
so where do you?
I live now in a town called Gravenhurst, Ontario. It's a couple of
Oh,
hours north of Toronto, up near Georgian Bay.
oh, okay.
That
I'll track you down.
all.
All right, let's move on to something else too. And I apologize if I'm trying to pin you down on certain things because I respect what you're trying to say, and at the same time, I'm also trying to, because I've found, again, reading your books, little hints that I thought helped me a lot. And I'll get the next thing I wanted to move into, and this is really important, is stretching. And we frequently see professional athletes doing lots of stretching, right before the game starts. The weekend warriors like myself, we try to put a little stretching in. We're not always so great about it. But one of the things I learned from your books, which to me was very important, like I mentioned again in the intro of the podcast, when I was having back pain in medical school, well, more in residency, it was pretty bad then. I would get up before work started, and obviously from sleeping all night, I was very stiff, and it seemed like the pain was like at its worst early in the morning. And I remember going to see a physical therapist, and they would say, do stretches. And so I tried it, 15 minutes before I was going to work, doing some stretches, and I'm like, this doesn't feel good, And I remember then reading in your books later on saying, that the spinal, the disc fluid is at, what is it as, it's at its like driest. Is that the proper term? Early in the morning, and that you're really
No,
better off.
it's the opposite. So you've given me so much to riff on there. First of
Okay,
all,
go ahead, Riff.
I'm doing pattern recognition as you're speaking. So
Okay.
when you tell me you wake up in the morning and that is the peak of your back pain, I'm going to look at your bed. So you may be laying in a bed that's too soft, allowing the spine to deviate into your pain. Now I'll just give you another subcategory of pain. There is L3, L4, L5. That's a
Right.
normal disc, and that's a normal disc. This
Right.
disc has lost stiffness and turgor because of a disc injury. Observe,
Mm,
I'm going to twist. Do you see how the majority of the motion is now occurring at the joint that's lost controlling stiffness? Those are
right.
called micro movements.
Right.
So if you lay in bed and the spine is deviated with a soft mattress, now you've created micro movements right at that level, and the symptoms will show us what level the micro movement is occurring. Then you forget about stretching, forget about everything else until you can deal with the primary cause, which was a sleeping posture. But then I know patients come in here and say, my physical therapist told me when I get out of bed in the morning to lay and pull my knees to my chest first.
Right.
Okay.
That was a classic.
Here's what happens. That fires a stretch reflex, which will give an analgesic perception for 15 or 20 minutes to the patient, so they perceive that they've done something good.
Right.
What they didn't realize was the collagen of their discs is an adaptable fabric. If you keep stretching it, it will become more mobile. I hope you enjoy your pain because you needed the opposite. You needed the collagen to the ground substance between the collagen fibers to stiffen up. Stop moving it. Stop the stretching, and slowly the pain will wind down, but you won't stretch that pain away. Secondly, if it's a sensitized nerve, you will not stretch the pain away.
Right.
Now think of all of the people who come in and they say, oh, with my back pain, I've got tight hamstrings. I stretch my hamstrings all the time. And I say, tell me, how long have you been stretching your hamstrings? Oh, I've been doing it for months. I said, and how well has that worked for you? Stop stretching your hamstrings. So there would be an argument for that particular subcategory, stop stretching. Now let me play the other side of the coin. We've measured in certain types of back pain categories, neurogenic facilitation. Consider having a sore knee, you will limp. That's what your brain does as a facilitation. Your brain causes body parts to limp in your back. If you have hip pain and back pain, those who have this sequelae, shall we say, they may have what we call gluteal amnesia. The brain preferentially decides, let's not activate your gluteals and we'll get the hamstrings to extend your hip. And that will cause, over time, extra stress on the hip and the spine. That is an inhibition of a muscle. Now, here's the opposite. The brain, if you sit too much and cause discomfort from sitting, generally, not in everybody, but the assessment will show they get neurogenic facilitation, the opposite. The psoas muscle, which crosses the hip in the front. The person gets out of the chair and it's hard for them to stand up because of the stress.
Right.
So there, I said, don't stretch your hamstrings. Now I'm going to say, stretch your psoas. So we would take a lunge position. If I can move back far enough here, we take a lunge position. I can even palpate the psoas tendon in the iliopectineal notch. There, it's soft. I've done a lunge. I'm stretching my hip flexors, but there's no load on the psoas tendon until I put my hand right up overhead and lean away and drop my shoulder. Now I just felt psoas tendon become tight. So even the stretching technique matters in terms of addressing the real cause. So there's a facilitation and inhibition, why you might want to stretch and why you must not.
But
all depends on the assessment.
Do you have like a strong feeling about, let's say, waiting till till a few hours once you've been up and moved around, or maybe taking a hot shower and you're looser? Would you,
Well, yeah, because you're taller when you wake up in the morning than when you went to bed at night. The reason is the discs are hydrophilic. They suck up fluid throughout the night. Throughout the day, hydrostatic pressures from gravity and muscle usage squeezes fluids out. So if you're typical, I would measure, you would be about 2 centimeters or almost an inch for you Americans, 2 centimeters taller when you first get out of bed in the morning. Then when we stress the spine, the discs are like little water balloons. The stress is much higher in them. So when you squeeze them, you're much more likely to have an end plate fracture in the middle of the end plate and not on the edge. That's a more light end of the day kind of injury. But some people, they get up in the morning and they're just so full of fluid. Did you know that astronauts, for example, when they go into space, because gravity is not squeezing fluid out of their spines, they grow a couple of inches. They get puffy face syndrome as the lymphatics milk fluids back upward without the gravity, which is now absent. There's also their eyes pressurized. There's all sorts of medical complications. But anyway, they're on spine pain the whole time. So here now is a person who, we did another experiment where we put people to bed for 8 hours and we measured the hydrostatic stress inside their discs. And then after 8 hours, they got up. And then other groups we let stay in bed for 36 hours. Their spines were in so much stress, they were screaming. So, you know, the old days of telling people to rest in bed, I hope you enjoy your pain because you've just put your spine in stress. You must get up out of bed and walk around and squeeze out some of the fluids and reduce that pain generating hydrostatic stress.
Yeah, that's a good point.
Yeah.
Well,
so,
because the old recommendations, especially from physicians, I wouldn't say it anymore, but in the old days, they would say, lay in bed, stay in bed for a couple of days, ice and take some pain meds and you'll be fine. That was the, you're right. But I mean, that was I don't know about in Canada, but in the US, maybe, 15, 20 years ago, that was the standard, of care. So let me ask you too about some, I'll call them stretches. Some people might call them yoga movements that you recommend in your book. And I've used them. I think they're kind of good. The cat camel pose, where you make the back concave and, convex. Also something called cobra, which I think a lot of people are familiar with now. It's sort of a little bit of a hyperextension. It's almost like a little bit of a push-up. And one of the things too that somebody showed me, I don't know, I used to always like it because I really felt it stretched out my back, I think the yoga name is called the plow, like where you bring your legs over your head. And George Sheehan, who was a doctor who led the running movement in the United States like 25 years ago, he used to have like what he called his magic six. There were like, a couple of these exercises that he swore helped him, avoid injury for the most part in running marathons. He was a big marathon runner. So anyway, what about a couple of those stretches overall? Beneficial? I mean, you mentioned them in your book. Are they dangerous for anybody? Are they overall safe for people to?
Well, they will cause pain in some and they will really help others. So that cat camel, now you called it a stretch. I do not. I call it a mobility movement. We would never use it as a stretch because you don't push the end range.
Right.
It's simply moving the spine back and forth.
Gentle motions, right. Mm-hmm.
Which reduces the friction or opposition to movement to allow the spine to move more freely. If that's what the training target is, the cat camel on the hands and knees is a superb exercise, but we wouldn't push the end range. But my colleague, a fellow named Bernie Clark, wrote a book called Your Yoga, Your Spine. And he coaches the person through an assessment of their anatomy and their pain triggers. And there's a course by Yoga International where both he and I have collaborated on it for yoga practitioners to perform a self-assessment. So they know their pain triggers and they know what yoga exercises are guaranteed to trigger pain and which ones will provide.
Oh, that's very interesting because I know a lot of people that swear by yoga, but I know yoga instructors some of them who've had debilitating back pain. So it's interesting that you say that because people always thought of yoga as the cure-all for back pain. I mean, that was,
Well, I don't know too many people who have a good outcome who say that. Now, having said that, I suggest you go to your hip surgeon colleague. There's a few in New York and say, what's the demographics of the people in your waiting room? And they will tell you, if they've studied them, they will be women in their 50s who've practiced yoga for 20 or 30 years, now requiring hip replacement. Is it the fault of yoga? No, it's partly the fault of the Americanization of yoga that turned it into this game of how far can you stretch versus the original Indian origins, which was all about transcending the mind.
Yeah, I want to bring up something too. I mean, again, this might be very basic to you, but it was something that I learned over time because I ended up, doing over the years. I've done some yoga, but see, what's really interesting when I had early on had the back pain, you see a physical therapist, they would teach you stretches. But the one thing I felt that the physical therapist didn't do, which yoga did, was teaching you to breathe into a stretch. I don't know again now how you feel about this, but I've always found it like it's almost like you're more in tune with your body versus just pushing through something. When you have to breathe into a stretch, I don't know. I feel like you feel it more. You know what your limitations are. Any thoughts on that?
Yeah, I've got very wide thoughts on this,
Oh,
primarily
no.
because we've measured it.
Okay.
That now you're getting into the very mindful part of yoga, which we cannot deny. However, again, some yoga practitioners take this way too far and they start teaching yogic breathing to athletes. Wait a second, you will be crushed under the basket in the NBA if you are doing yogic breathing. Instead, you must stiffen your core, box out your opponent, and they are waiting for the second for you to do a yogic breath, relax your core, and then they nail you. You are out of position. It is martial arts under there. So, you know, again, there's very little transference from yogic breathing to the field of play. But now I've got another surprise for you. We measured the St. Louis Cardinals. They won a little thing called the World Series, which we in Canada always feel funny because
you know what baseball is up in Canada, right?
well, somehow the Americans forgot to invite the rest of the world. But anyway, it's called the World Series. So this
I thought you guys only know about hockey.
this little team called the Cardinals won the World Series. Well, the year they won the World Series, plus the year before, we measured every single player, and this was through my colleagues at the Central Institute for Human Performance in St. Louis. They measured a full fitness profile, strength, endurance, range of motion, and movement ability. And then for the next 2 years, we tracked to see which player, by the way, the pitchers were out, and we had the 3 farm teams. So we had the big show, the Cardinals, and the 3 AAA farm teams, or whatever they call them. We had 96 players, I believe, and then we saw who got back injury over the next 2 years, plus any other type of non-traumatic musculoskeletal injury. Do you know that we were able to predict, I think we had 4 or 5 back injuries, I can't remember. We predicted by doing data mining, looking at the scores and putting it into an algorithm to see if certain fitness variables and movement profiles conspired together to allow, and I use that word allow, that person to sustain a back injury. And you know, we were able to predict the 4 or 5 with 100% accuracy who had a back injury, and even more spectacular, we were able to predict with the same algorithm the 92 who never did get a back injury. Wow. Now, what were the variables? The first variable was hip mobility and how well they were able to move their hips with proximal stiffness and control in their core. Right. So if I want to push and I move my spine, that's an injury marker. But if I lock my core and give a very athletic push, that uses the spine as it's meant to be to give it full sporting potential. Okay. But the other variable was breathing mechanics in a quiet state. So do you see how I have to play both sides of this because it's very situational dependent? Right. So that's why here I've got to bring in the precision, and I know you have to teach this to the masses, so you need consumability, and that was the struggle in the book. Yeah. And you see it playing out. Well, now.
Yeah, I mean, because I think sides. I'm going to get to this next thing because I don't think I'm an outlier in this. So many guys, especially, we all want to have sort of a nice core. I'm not saying I have to have the 6-pack ab, but you want your core to be not sticking out, arriving before you do, and. A lot of times, especially when I was younger, I used to buy those magazines, I'm waiting at an airport, and I'm talking about, there was Men's Health, all this stuff. And they always had pictures. Of course, they had some guy who was super cut, but doing these exercises. And you say, I could do that. You know what I mean? And and before I knew it, I was in trouble, And what I liked about in your book, there's some really basic things, which, I think achieve a lot without injuring yourself. I mean, you talk about the abdominal bracing. I want to get to this, and the shortstop stand, which I try to do every day because, as I said, it's just, they're simple and they seem like you're not going to hurt yourself, And so I was wondering again too, with the abdominal brace, remind me again too, I think you showed in the picture that you put your fingers into the sides of your abdomen. So it's not necessarily tensing your abdomen. It's putting it into the side. I think it's,
Yes, there was a movement in physical therapy a number of years where you draw in your abdominals, and this creates a brace that will protect you. We found out this to be dead wrong. We would put weights in someone's hand and tell them to suck their belly in, and we would measure the stability go right down, or that they would be performing a squat. They don't suck their belly in, the great squatters. They do the opposite. They actually push it out to make the guy wires big and robust to protect the back. So here is what we've measured truly enhances spine stability. So there's my navel. Take your fingers lateral to the rectus abdominis, or the linea alba, and then go lateral. Now push your fingers in. Now push your fingers out laterally. Bingo. And that is the brace. Now,
is it like a 1 second, 2 second thing? Is that what, that's all it is? It's just pushing it in like that?
No, it is.
You hold it?
Yes. Now it's tuning the brace to the activity.
Okay.
So someone who walks, who has the joint micro movements that I showed you earlier, require a 7% of maximum brace when they're walking to
keep their
pain away. Now they have to walk up the stairs. I've got the hip flex. I might need a 12% brace to slide up the stairs. Or I'm now going to open up my car door. To avoid that little shot of pain, I might need a 20% brace. Now I'm standing, I'm hovering, my ears over my shoulders over my hips, and all of a sudden, oh, fabulous, I'm standing with a 0 brace. So do you see how the amount of bracing is a tuned effort? Are you with me?
Yes.
Sorry, I just lost my earbuds there with my exuberance. But
bracing, I don't think it really comes through in the book on that, though. So you're saying the abdominal brace varies depending on...
Absolutely. When we had one of our athletes 2 weeks ago set the all-time world record in squatting. He squatted 1,306 pounds. He came to me, started as a back patient in 2013. He was a power lifter. He had a world record, but he couldn't bend down to tie his shoe at that point.
God.
But he came back and set the all-time world record. Now, how much bracing do you think he does?
I don't know.
100%. His muscles are activated to 100%. But should a normal person do that? No. But there's all kinds of drills, Dean. I could do a side plank like this. I'm doing a side plank, and I breathe through a small hole. Now, do you see how I've got to activate the muscles on this side and still breathe, which I'm turning the diaphragm now as the athlete breathing behind the shield, and the shield is what buttresses the spine to take out that micro movement pain trigger, if that is the subcategory that we're talking about. So there's a drill now to tune the level of the brace so that I could go to the gym at night and I could do a round or two of boxing. I might do whatever it is I'm going to do. I might ride the Aerodyne bike. But you've just given yourself now the neural wisdom, or the new, you've heard of muscle memory.
Of course, so important.
We're creating muscle memories now that are banked in the brain. And then the brain pulls out the most appropriate muscle memory program for the task. Now, some people get back pain because they're choosing the wrong muscle memory. So they get the tuning all wrong. Those are the people who need to see one of our master clinicians. And by the way, we've got two or three in New York City.
But how do they find you? They go into, is it under McGill, or is it under, like, how do they?
Our website is BackFitPro.
BackFitPro.
Yeah, just go to BackFitPro and then look under clinicians. And all of these people, we that is not an easy designation.
I can imagine. Yeah, no, I know. So also even things like the plank, which you just start to show, you know, like, again, typically every magazine, you see people doing I guess, whatever it is, the frontal plank,
and then the side plank. Sure.
Plank place. I mean, again, most people should be able to do that, or not for everybody. It depends.
Well, if you've got a torn rotator cuff in your shoulder, I hope you don't do it, because your shoulder will become disabled.
Really? From the
Well,
from
if you had
oh, right, right,
you
right.
couldn't do
What
it.
about your ankles? I've had ankle surgeries. Sometimes when I do the plank, I find my ankles hurt. Because are you tensing up the ankles a lot and all that too? Is that
Yes, so we engineer it out.
yeah.
What we would do a side plank from the knees and the elbows.
Yeah, I've seen that in the books. Yeah, I've seen the photos.
So here's the thing, you're giving me one of situations, and in every case, we will engineer a hack, a movement hack around that
right,
to
right.
spare the load off the part of your
See
body.
that right? That makes so
hurting.
much sense what you're saying, and because see again, Dr. McGill, that's what you realize what happens out there. People see in these magazines and stuff these exercises, and they think one size fits all. Oh, if I do this, I'll be shaped like this guy. And what you're really essentially saying, and I want the listeners to appreciate that, because I've kind of learned it the hard way myself too. Like I know certain exercises I stay away from. I run into trouble if I try to do certain things, and if you try to push through and say, "Oh, I'm just not doing it enough," whatever, you get more injured, right? Am I saying that correctly?
You are, but every exercise is simply a tool. Now, I could say, oh, I hate deadlifts or I hate kettlebell swings. And then the next person comes in and I'll say, the best thing for you are kettlebell swings and deadlifts. I love them. So there's always a context. I wrote an article where we investigated the mechanics of kettlebell swings a number of years ago.
Yeah, that became a big thing here. Yeah. Mm-hmm.
The opening paragraph was a quote from a world record holding power lifter. And he said, after my herniated disc, the kettlebell swing was the magic that grooved the muscle memory and the hip hinging pattern that allowed me to restore my training capacity. Then I quoted again the other side of the coin, the next athlete who was a super athlete. And they said, I can do anything except kettlebell swings really set my back off. So again, there's a mechanics to a kettlebell swing, and there are sometimes you can create a movement hack around it. You will see the great Russian kettlebell master Pavel Tsatsouline, when he swings the bell, when the bell comes to horizontal dead center, he tightens his core with a pulse. And you hear the guttural effusion of the breath.
Wow.
That is a very stabilizing technique while you're at the top of the swing. Will that work for the next person? No, it might set their back off, or it might help them. But the assessment is king. I keep coming back to this. It will.
Let me ask you two popular sports here in the United States. I think in Canada as well too: tennis and golf. As I mentioned in the introduction, I was a tennis player in high school and college. I love tennis. I hadn't played for 15 years. I had ankle surgeries and stuff, but I started playing again, and I'm in love with the sport. I love playing it. I know friends of mine who are golfers, and I know you mentioned this in the books too. So maybe just to clarify, the twisting motion is one of the more treacherous motions for the spine. Is that correct?
Yes and no. As you know, we've restored some of the careers on people who are currently on the tennis tour.
I did not know that. Are you allowed to name names?
Tennis, no. And also we've restored some pretty high profile careers in the PGA Golf Tour as well. Now, I'm sorry for the layers, but we have to be real. First of all, the size and the architecture of the person's spine really matters.
Okay.
So the great golfers have open facet joints, which allows the spine to twist.
There's that rapid force. You see Tiger Woods at his peak, the amount of torque. Let's talk about a little physics. Am I correct? I mean, when you see a 6
yes and no.
guy and spin, I just picture their spine, because it's almost like a baseball player when they swing that bat. And you just picture their spine twisting, like a corkscrew.
Well, that's not necessarily a bad thing for Tiger Woods.
Yeah.
However, have you ever seen a middle linebacker from the NFL who can hit a 300 or 350-yard long drive?
Probably not. Right? Yeah.
Because
they can't get
their spines are too thick. So if you took a thin willow branch, you can bend it back and forth without much stress.
Right.
But if you took a thicker branch and bend it, the stresses would be so high it would shatter after one or two repetitions.
Okay.
So this is why thick boned, skeletoned people shouldn't be doing sit-ups. Golf is really not the best thing for them. And then you get a thinner boned person and a thinner spine, twisting is fine, but don't have them Olympic lift. So there's now, particularly in the US, there's people who mix up training philosophies. Oh, get stronger.
Well, do you see the golfers today too? A lot of, I mean, really compared to the Arnold Palmer days, I'm not a big golf fan at all, but the golfers today are pretty cut. They look very muscular.
Well, hold on. Yes and no. There are plenty who aren't. And now look at the length of their careers. You can look at, no, yeah, I'm just saying you can look at Arnold Palmer or Jack Nicklaus or any of these people who, yes, they had back issues. However, they didn't weight train. And that allowed them to play for many
longer periods. Interesting.
Those who weight train may have a slightly better golf game. It's interesting when you really measure the performance, with a few exceptions, of course, but on average, they don't get that much more yardage, but they shorten up their career. So you see the nuances here?
Yeah, no, I do. And I said, we're trying to cover a lot of ground here. I mean, it brings up another point I wanted to ask you too about weightlifting. Like, again, myself too, I'm not doing powerlifting, or power squats, but if I wanted to lift, 10-pound weights and do curls and stuff like that too. I mean, we know, one of my other favorite books is called Astrofit. It's by, who's it by? William Evans. He actually used to work at, I don't know if you know him. He used to work at Tufts. Now he's at, I think he was at Arkansas. He worked for the NASA because, again, all these astronauts who had, from being in zero gravity had loss of muscle mass. And he was one of the ones who really promoted the term sarcopenia, where your muscles get so weak. And, so people, obviously trying to avoid osteoporosis and other things. They even have, elderly people lifting weights. So what is, again, some type of overall recommendation you could make to people who want to get a little bit stronger? Not to power lift, but so when they're lifting their groceries and they want a good quality of life. What type of recommendations would you have?
Well,
general rules.
General rules, you got to follow back mechanic. I'm sorry to put it that way, but
follow back mechanic, your book.
Move well, number one.
Right, of course.
That gives you a training capacity. Now, I need to know your injury history, and I need to know the goals that you're training for. And then we will create a dynamite program that allows your body to adapt. So you threw in osteoporosis, and then you left that and you went on to something else. Every single one of those needs a very specific mechanostimulation. If you want to grow bone, there's not too much you can do to grow more bone when you're older. However, you can prevent further loss. How heavy the weight is a little bit of a myth. It's actually the acceleration of the load that stimulates bone retention.
Right. Well, they say that's what the whole thing with eccentric exercises, right? By slowly going down. No,
you're on the wrong track.
Okay.
I'm sorry.
No, clear me up. I don't want to, because I said,
don't walk with the shock absorbing shoes. It just spread the pulse of heel strike over time. That won't retain bone, but it's the rate of acceleration. So if you wore a sharp soled heel and created a sharp little click, that stimulates bone retention. And I can explain the mechanic of it.
No, that's actually, what you bring up is very important. It's really interesting. Evans in his book said if he was going to recommend one exercise to elderly people, or again, even women trying to strengthen their bones, especially in the lower legs, it was the what do you call it, the heel drop. They've done studies on this where people go up on their toes and then come down,
create a sharp impact. Of course.
So
this has been proven as the mechanical stimulus to retain bone. However, be careful. If you do too much of it, you will create microfractures underneath the end plate where they will accumulate over time. So now you're going to love this. I'm I don't know how old you are. I'm in my mid 60s and I have zero pain. I feel fabulous.
You look great.
Well, at one time, I mean, I've had a lot of trauma
Oh, yeah.
playing sports and whatnot
Okay.
over the years, but now I train with what I call the biblical training week.
I
And
like
what that
that.
is I have one day off a week,
Okay.
rest. If
Yes, makes
people
sense.
would only rest for one day and allow their body to adapt one day a week, they would be
Absolutely.
so better off.
Yeah.
2 days a week, I purposefully strength train. In BackFitPro HQ here would be one example.
Okay.
2 days a week, I work on things that are a bit stuck. So I've broken my neck, I've had hip replacement and, things that I have to look
Okay.
after from a
Right.
mobility point of view. So
Right.
2 days a week, I do strategic mobility
Right.
work.
Right.
2 days a week, I do something for my ticker. I'll go for a bike ride in the
Uh-huh.
summer or a swim, or in the winter, I'll go out for a ski or whatever.
Okay.
So, and then the seventh day, I don't do very
Rest.
much.
Yes.
And with that generic formula, if that's what you want, the biblical.
I like that. Thank you. Well, it's so funny that you mentioned that. A lot of times I tell patients I advocate the biblical diet, and that involves two things. That involves eating foods as fresh and in their natural state as possible. And I also like my rule of twos for eating. I always tell patients, if you're going to eat fish, eat it twice a week. If you're going to eat meat, eat it twice a week. And then, 2 other days, eat vegetarian, because the variety, I think, is good for the mind. I think it's just good for everything. So I think we have some common ground on your rule of twos, but I like that. That's a good takeaway, because I do too. I also sometimes think people are so focused on, oh, I got to get my 3 days a week of weight training in. I got to do this. And have fun. You know what I mean? If this is your day, you're going to, do your racket sports or do something else too.
3 days a week came from bodybuilding with the sole goal of hypertrophying.
Yeah, a good point. Yeah.
Yeah.
All right, we're kind of winding down here, but there's 2 last topics I do want to get to, and again, we'll see if I can pin you down on something. When is it, and again, I think hopefully the answer would be never, but when is it appropriate to have spine surgery? I mean, I'm just asking, like, when you've seen cases of where you say, look, I can't help this person unless they get an operation. Is there any, like when a herniation is so extreme, or and anything that just kind of jumps out at you that where, again, somebody should be, after they've had appropriate treatments, like you said too, you don't want to be also, like you mentioned this book, which I think is great. Like, you don't want to go to a doctor that says, okay, you're going to need 6 months of, 3 times a week manipulation or something. But just regarding surgery, and again, I'm not a big fan of spinal surgery, and most people seem to do very poorly after it. And Tiger Woods, unfortunately, seems to be one of those cases. I mean, again, I don't know all the details there, but again, when would you think someone would maybe need spinal surgery?
Well, there's a whole chapter in Back Mechanic on making the decision, is surgery right for you?
Mm-hmm.
Absolutely. There is a time and a place for spine surgery.
Okay.
There are cases that we uncover that the person didn't even know existed, where spine surgery, they might have a Tarloff cyst, a nasty little cyst on one of the nerve roots, as an example.
Okay.
There's not much we can do until we get that cyst to allow the nerve to slide. So there might be an example. However, considering surgery is a risk, and we want to maximize the reward and minimize the risk ratio. So I go through rules. First of all, you have to peg down the surgeon. Can you prove that the thing you're going to cut out will remove my pain? And if they are doing exploratory surgery, I'd run the other way.
Yeah.
If they're going to work on more than one level, your chance for success of cutting out your pain drops dramatically.
That's a great point. Okay.
We give plans. You may have been told that you've tried physio, osteopathy, chiropractic, etc.
Right.
Because you failed all of those, the last thing for you is surgery. What a terrible route to surgery.
And wait, I'm sorry to interrupt you again. Just also when I use the word surgery too, and also I hate to throw in there's the pain management people. They're busy implanting these devices in people, and I consider that a surgery when they start putting those stimulators in. That's a surgical, or whatever you want to call it, procedure, right? So.
Well, it is,
And I've rarely seen successes with that, honestly, with my patients that have gone through that, route.
well, everyone I see is a failure. So
Yeah.
I'm
Mhm.
never the first person they've seen.
Yeah.
Usually the last straw. But I will say this: we perform virtual surgery, and it's a program. We precisely define what their pain triggers are. We stop the cause, and then I touch them like I'm knighting them with a sword, and I'm saying, there is your virtual surgery.
Mm.
Surgery works on many people because for the first time it's forced rest. So now I've just heard this woman, she's a stay-at-home mom. She says, every day I have to go to the gym and ride the elliptical trainer for 40 minutes. Otherwise I'll
Yeah.
murder my husband.
Exactly. Well,
It's the way I relieve stress. And I'll say, and that's why you never get better. You're an exercise addict, and every day you pick the scab on your back. So go have your surgery. And it may work because for the first time it's forced rest. But
oh,
I'm
great
going to
point.
offer you
Great
that.
point. Yeah.
Now I'm going to perform virtual surgery. There's your surgery. Now start acting like you're post-surgical. You're
Right.
going to rest, and I'm going to build a program with short interval walks. We'll get the various tissues that ought to be moving, flossing and moving. We're going to build some core stability. We're going to build some strategic mobility in the distal parts of your body, and we're going to do it in a progression to build you all back up again, just like good rehab should do. Now, this will
Mm.
knock your socks off. We follow up with every patient I've ever seen in the entire history of the university. I know exactly our outcome score.
Wow.
If you have been told that you've tried everything and surgery is your last resort, when we do virtual surgery in the way I've just described, we have 95% of those people who avoid surgery, and in a 2-year follow-up are glad that they made that decision.
Wow. Wow.
So
Huge.
there is some evidence
Wow.
base.
Yeah.
And again, they follow the spine hygiene and the
Mm-hmm.
strategic approach of back mechanics.
Wow. Wow.
But there's still 5% of the time that
Mm-hmm.
surgery will.
Well, but that's a very, very small amount compared to probably what goes on, and especially, as I said, the procedures that, again, I think a lot of people, like, again, like, you used to hear people getting laminectomies and, disectomies, I don't know, all these ectomies, and they weren't any better, or not for very, maybe for temporary, and then they relapse, and then these people end up in pain management, getting either stimulators put in or medication, anyway. You
Well,
know,
here's another part in that chapter on should you be considering spine surgery.
mhm.
Ask the surgeon what the cause of your pain is. And if they say, we don't know what causes back pain, run the other way.
Yeah, that's a good.
Because you have a herniated disc for a reason. There is a very specific reason why that delaminated collagen right there ended up with a
But that can also heal, correct? You see a lot of these athletes that get that. You'll hear, "Oh God, he herniated his disc, didn't have surgery. He gave it rest. They did stretching." Conservative measures, those things can get better. I think people also tend to think that once I have this, I'm doomed.
we have athletes in the UFC, the NBA, the NFL. I can go on ad nauseum. Almost every Olympic sport, all coming from a place of back injury and herniated discs and all the rest of them. So when you perform the right mechanical stimulus to get the right adaptation in the body, you can we're not this degenerating body. There's no
Right.
such
I
thing
know.
as
That's what people feel like, they're
degenerative disc
broken.
disease.
Right. I think people feel like they're broken and they don't realize you can heal,
The body is desperately trying to regenerate all the time. Everything can
Yes.
regenerate except your teeth, but they thwart regeneration by childish nutrition practices, unprofessional exercise, et cetera,
Hmm.
et cetera. So I know I'm sounding fairly opinionated, but I'm
It's okay.
sorry.
We like having that here.
I'm going
I
to
like people that are
stand on
bold.
I'm going to stand on our
No, I
evidence
think
that
it's
we've
excellent.
created over the last 30 years.
The last thing I want to get to as we're finishing up, I love this discussion, but the last thing I want to ask you about is, as you just started to allude to a little bit, the stress component. One of the doctors I consulted for my back pain when I was first in medical practice, in private practice, who I still to this day have a tremendous respect and admiration for, is Dr. John Sarno. He was, I don't know if you've heard of him, he was the former chief of rehabilitation medicine at Rusk Institute at NYU, a very prestigious rehabilitation center. But Dr. Sarno became very controversial, I guess, midway through his career, because he had felt that so many patients did not improve with the physical therapy that they were prescribing, and that a lot of these patients, their back pain was not actually physical, but in fact due to emotional factors, what he called subconscious rage, fear, and anxiety. And I found it very interesting. I found at the times doing his program, which I went through back in, I guess, the 1990s at some point, helped me. But I'm just curious about, because I know you do mention a little bit too, that the role that emotions do play in back pain, and if that's something that you also incorporate into your programs.
We do, but not probably in the way that you think. Can you imagine going to the world's expert or a doc or a surgeon and they tell you how to get your back better and they just made you worse? You would become despondent. Then the person who there's no checks and balances in their ability to create a great outcome. So their feet are never held to the fire, that particular clinician, and they go and tell the next person and the next person. Now you've been to 5 different experts. Every single one of them have failed you or made you worse. Wouldn't you be psychologically distraught?
Sure.
And then this is the rub. Now a lot of physical therapists are defaulting and saying, well, you didn't respond to the exercises. The pain is in your head. You are magnifying your pain. Now the person is really in psychological distress. What, am I crazy? And I get people who are now, I never used to get them, but we get them now. They are suicidal because they say, the therapist told me the pain is in my head. I don't think it's in my head. I think it's in my back and my leg. But if it's in my head, it means I'm crazy. And if I'm crazy, I don't deserve to live. And we have this terrible dissonance. So do I treat the psychological with cognitive behavioral therapy? Yes and no. What I do is I assess them and show them, here is the cause of your pain. And almost immediately, we give them the mechanical antidote. Try this. Bend down. You mentioned the shortstop squat. Instead of bending down like that, slide your hands down your thighs and play shortstop.
I like that one. That's one of my favorites.
Now, instead of lifting with your back, pull your hips through. It's a different way to think. And they'll say, oh, caused my pain. And I said, good. Bend down and pick up that kettlebell. Who's your grandson? Do the shortstop squat. Drag the kettlebell up the front of your pants, pulling your hips through. Did that cause pain? No. Then all of a sudden, the psychological fear of movement just turned to confidence. I just did something. That's a little bit of coaching, and now I am empowered. It's
that's important. That's super important.
So did I just do a psychological intervention, or did I do a mechanical hack that empowered the person to take their own pain away? Which
I think you did both.
Exactly. Bingo. That was the answer.
I got that one right. Finally, at the end of the.
So you see, do we consider the psychological is very powerful?
I think so.
But I think there is people who would not do what we do. They say the pain is your head. We're going to give you cognitive behavioral therapy.
Yeah, I think disrespects them, or it kind of goes against what people really, I think understand the mind-body connection. They're so
But having said that, there's a person who has a cough and a sneeze and they're off to the doctor. Those are the ones who are micromanaging every little ache and pain. Now, those are the ones that we can say, what's your pain? Oh, the pain's an 8. And they're just standing there. I said, it's not an 8. If you were shot, that's a 9. So come on, this isn't 8. Your pain is about a half. Could you give me that?
Right.
And we recalibrate them that way. So there's a time and a place for that cognitive behavioral calibration of
and also too.
I'm arguing the other way on.
I know. I said you're good at that. You'll be a very good lawyer. But the thing is this too. It's also, I think too, with a lot of times people love their physical therapist or their chiropractor or whoever. It's it is also still the healer relationship. I mean, people want I'm sure you've seen this too, because dealing with chronic pain and back pain, that people want to feel that someone cares about them, that that they're not in it alone. I think that's one of the most frightening things for patients when they, I have people, because I call myself the 10th doctor. I see a lot of very complex cases, in medical issues like immune conditions. And they'll say, I've been to 9 other doctors. You're my last hope. And, I start out almost like discussing with them saying, when I hear their story, I think you're in the right place. And, and we're going to go through this together. And that alone eases some of the pain, which I think, in medicine, that's sometimes got forgotten. But, I can tell you, as I said, I know like people who love their physical therapists, some of them the chiropractors, who spend time laying the hands, touching them. These are things that got lost in medicine, or coaching, as you do. I mean, I like to say also again to my patients, like, I'm not just your doctor, I'm your coach. I'm going to try to take you through my experience, because you could look up on Google and diagnose your symptoms or, whatever you want to do. But if I've seen 1,000 cases of this, I hopefully can use my experience in helping, get through this. Anyway, we have had an amazing discussion. At least from my side, I have learned so much. As I said, I am a huge fan of yours. As I said, for years, I've read your books, and I didn't know we'd ever have this podcast. So in summary for our listeners, back pain can be frightening and incapacitating, but it can be treated effectively with proper diagnosis and care. So find a good healthcare provider that spends time evaluating you and teaching you how to be self-reliant in your care. And as Dr. McGill mentions, he's got certified people that he's trained through BackFitPro.com. I would encourage our listeners to go there and work with somebody to identify the key stretches or exercises that make you more flexible and active. And again, I just want to thank Dr. Stuart McGill for taking the time today to teach us all how to be free of back pain.
Well, thanks so much for hosting and all what you do, Dean.
Thanks a lot.